So, when we do our preparations of posterior teeth on upper jaw, the position of the patient is still the same, similar that like we did for canine with direct vision. So, if patient is in a horizontal position, then you can ask your patient to move chin up if patient doesn't have any osteochondrosis. Pillow, chin up, and then you can see occlusal surface direct. If you want to see it even better, what you can do with your microscope, or if you don't work with microscope, you have to move yourself more forward. If you work with microscope, you can move your microscope forward, tilt it back a little bit, and you can get better view over the occlusal surface with direct vision. In my case, you can see that we have pretty, how do you call it, pretty thin walls, unsupported enamel, like shell. So we have to create space for restoration, and we have also to rely on the thickness of the walls. So what I will do, I will take depth cutter, and we have it in our bore kit, this square depth cutter, and this bore has 2 dots, and you can see the distance from the tip of the bore to the first dot is exactly 1.5 millimeter, which is average requested thickness for the material. When you rotate it, when the bore rotates, it creates the gray line. So that can be also your reference when you start doing this prep. So you put your bore vertical, you press on the pedal, you can see this gray line, then you go all the way through the tip of the cusp, between cusps, again, the tip of the cusp all the way out. So each groove now is 1.5 millimeter in depth. So that will be my guide to get space for my restoration. So tips of the cusps and also the distance between cusps. This is what I use as reference for my preparation. Then you can take pencil if you want to mark these grooves, so that will be more convenient for you to control reduction, or you can just prep straight away. The same bore, we do not change it, we use the same one. Now we have to understand or to decide which angle we are going to use. Anyways, the one, you follow anatomical preparation or cuspal inclination. This is not very good for overlay preps. It's better to for crown preparations. You can get 90 degrees, which is okay for overlay preps. But if you would like to get some reinforcement, in that case, you may incline your bore more to lingual or to buccal side. So you will get your butt joint a little bit inclined to peripheral aspect of the tooth. And you will get few benefits out of this angulation. The first, you get better color transition. The second, ceramic or another type of material will go outside and it will reinforce the tooth from the outside. It literally creates external ferrule effect that may prevent breakage of the tooth or splitting of the tooth because of the cuspal deflection. So this is the angle that I would use for my overlay preps. I keep it with a buccal inclination, and I start and I prep these grooves all the way down. After that, I would evaluate the thickness of this wall, and here it's very thin. So what I can do, I would definitely continue my preparation here a bit down. I still have undercut here, but the thickness of the wall now becomes equal for occlusal forces resistance, so I can just fill this undercut later on with a composite. At the same time, I would also remove this sharp ends or sharp ridges from inside, like that. So the buccal one is done. There is unsupported enamel in very distal zone that I will take care of a little bit later. Then the same from the palatal side, palatal inclination for the bore. We prep the tip all the way down. Okay, then evaluation of the thickness. If it's fine, just remove these sharp internal ridges. And that will be fine for the cusp reduction. What's next? To get proper insertion path for this type of restoration, we have to open interproximal box. And in our case, it's very bad because we have unsupported enamel, very sharp, rough, and thin. So which board to use in that cases? It depends how much space you have between teeth. If you prep group of teeth, you can use 16 or 14. In my case, I do not prep 7. So I would be more conservative in such a situation. So I'll take 12, okay? And with the board number 12, I will just open my interproximal box. So I will move these preparations bit out to the buccal side and also to palatal side. To see better, we ask patient to move head more to the right, in my case, so I can get better view over distal buccal transition. So now, the board number 12, still high speed, a lot of water. So we start opening of this interproximal area. And I would like to highlight you a very important transitions here. So first of all, let me just remove this unsupported enamel and to open the proximal box all the way out. And now let me show you one important thing with a high magnification. All the time you prep for indirect restorations, you have to think about margins and to think about insertion path. So you have to think about your dental technician, by the way. What does that mean? When your dental technician will receive from your side scan, or he or she will receive impression and he will make a model, they will have to understand where are the outlines of our preparation. So when you do cusp reduction, the outline is here, the very end of our reduced cusp. It's sharp. It has to stay sharp, like that. Okay, so that's easy. In proximal is that. You can see it also clear, but where is the transition between proximal and between this prepped cusp zone? In my case, it's a very high and sharp ridge in transition between proximal and between reduced cusp, and that will be not possible to get fit of your restoration there. So what you have to do, you have to join proximal with this area. So how do we do that? You can look, I will not prep, I will just show you. So I prep proximal and then I move my bore gradually towards the prepped occlusal surface. So in that movement, you will get connection and it will be one continuous zone that will be very visible on your models and on your scans as well. So let me just do it in preparation phase. Okay, so that's it. It's done by the coarse or medium grit bore. With the red one, it will become even more smooth and clear. But since till now, it's fine. Then I turn head of my patient to the left, and I can do transition in this distal palatal zone with, you can see a lot of unsupported enamel. So that's the way we have to take this out. Let me make it faster. And the same way you have your proximal zone opened, but the transition is not good, so I would join this proximal with palatal side. Yeah, so that's better. Then mesial. How do we prep mesial with, for example, direct vision? It's not that easy, but if I would ask my patient to move head more to the left, probably I will be able to see that transition with direct vision. If not, I will do it with mirror. But in our case, we can do direct vision. So here we have that view, and I can open proximals with this thin bore. I can get preparation here in mesiopalatal side and also mesiobuccal side. And don't forget about that transition. This is not the end of preparation. We still have to move on. We still have to prep. But I think that it's time to do our CDO or cavity design optimization, because we still have undercuts, we still have rough areas, but it's almost 85 or 90% of preparation done. Okay? The only thing we have to do immediate dentin sealing or CDO, we have to improve our transitions. It will be done during step 2 with a red diamond bore, and that will be the end of the preparation. These type of preparations are defect oriented. These type of preparations are not retentive. They are mainly for adhesive dentistry, for ceramic, hybrids, composites. I'm not sure that you'll be able to use golden overlays in such designs of preparations, but for bonded restoration, that's fine. Okay, so yeah, let's do the same, and I will help you with positions. I will help you with your steps. So you start doing step 1, and I will help you and check everything. I'll keep the view like that, so it will be like a reference for your preparations.
Shall we do both?
Huh?
Do both or just the 6?
6, just 6. The premolar will be prepped for veneer overlay, so that will be different type of preparation. So that's just the classic overlay, and then we will go for veneer overlay preparations.